Yes, Charles.
Okay. Okay. Thanks very much, Matt. Good morning once more, everyone. My name is Dr. Charles Moyo. I'm one of the registrars here at the University of Cape Town. I'll lead a discussion today on penetrating neck trauma. So kindly note that I won't go into much about discussing the resuscitation principles according to ATLS, but you should note that resuscitation of all trauma cases should follow the advanced trauma life support principles, which I assume we are all familiar about. So if you look at penetrating neck trauma, it accounts for about 5 to 10% of trauma cases generally, with the vascular injuries being the most common injuries and being the leading cause of death in these patients with penetrating neck trauma. So over the past years, there've been a paradigm shift from mandatory exploration to a more conservative approach with clinical evaluation and more specialized or selective investigations. And then if we look at the etiology of neck trauma, you can basically classify it into three sort of sub-classification system. You either have got penetrating neck trauma, which is what we are going to focus more about today, which is commonly due to step wounds and gunshot injuries. You can also get blunt trauma. However, we are not going to discuss this in detail today. And you can get blast injuries, which is a sort of like a different entity. And we're not going to discuss this today as well. So in evaluation of patients with penetrating neck trauma, in addition to following your ATLS principles, there's been sort of like a paradigm shift from zone-based management to a sort of like a no-zone approach. So we find that we try to divide your clinical findings into hard signs and soft signs. Hard signs are serious injuries which require urgent operating room intervention, or which require a patient to be managed actively in theater. These include a patient with a severe or uncontrolled hemorrhage, a patient with a rapidly expanding hematoma, which sort of points to a major vascular injury, patients with thrills and bruises on examination, patients who are hypotensive or hemodynamically unstable patients who are not responding to fluid resuscitation. If they are absent or diminished radial pulses, which points again to major vascular injuries, and patients who have got neurological deficits, for example, a stroke. Again, you need to note that some of these patients, especially patients with neurological deficits, central neurologic deficits, may at times require imaging prior to intervention. And then again, if you look at structures in the neck, you also can get major aerodigestive tract injuries, of which the hard signs could be a bubbling wound, massive, if a patient has got massive hemoptysis, patients who are distressed, they need urgent intervention. Patients with massive surgical emphysema are sort of like, there is a bit of controversy there. If is it really considered hard sign, or you can, at times other people can classify it under soft signs, but you also need to correlate these clinical findings with the patient which is in front of you. At times you get patients with, for example, gunshot injuries with a bubbling wound with massive surgical emphysema who need urgent intervention. But however, a finding of a massive surgical emphysema in a stable patient may allow you to a leeway to go on with a specialized investigation. Again, you may get patients with soft signs. These are patients who are fairly stable in these patients, you have a leeway of doing some specialized investigations depending on the extent of the injuries. So it is of paramount importance that you do a comprehensive clinical evaluation in these patients, which is sort of like will guide your targeted investigations. So some of the soft signs you need to note about proximity of wounds. If your wounds are sort of like in close proximity to major vessels or the aerodigestive tract, you need to have high index of suspicion of vascular upper aerodigestive tract injuries. Patients with mild hemorrhage, mild hypotension responsive to fluid, minor hemoptysis or hematemesis, a subcutaneous or mediastinal A or some surgical emphysema, patients with a non-expanding hematoma, and patients with dysphonia or dysphagia. So these patients are amenable to a more conservative approach where you implement a careful clinical evaluation and targeted investigations. So if we look at upper aerodigestive tract injuries, you can divide them into pharyngeal esophageal injuries, though we will concentrate more on the pharyngeal injuries since our cardiothoracic colleagues usually manage the esophageal injuries. So if you look at pharyngeal injuries, they are no pathognomonic features, but you should have high index of suspicion in patients with dysphagia, patients with blood-stained saliva, patients with hematemesis, and even in patients with surgical emphysema. At times, we see these patients already intubated in the trauma unit, and you can look on them, and they've got a nasogastric tube already inside you. At times, you can look at the nasogastric tube. At times, there is some blood in the nasogastric tube, which could as well be suspicious of either a pharyngeal or esophageal injury. And then you have patients with laryngotracheal injuries. These patients may present in respiratory distress with stridor, hemoptysis, anterior neck tenderness, or dinophagia, dysphonia, or surgical emphysema, etc. So as sort of like examples, I will present just a summary of two short cases that we managed sometime in January and early February. So the first case is a 29-year-old male patient, still admitted in a ward. He sustained a zone 2 neck injury. He actually slit his throat just below the hyoid cartilage in a suicide attempt. He is also known substance abuser, and the wound was already sutured and he was intubated from the referring center. And then he subsequently had a CT angiography done, which excluded major vascular injury, and noted that he had a moderate surgical emphysema, and they could not exclude a laryngopharyngeal injury, which sort of brings us into the topic of some of the limitations of imaging. So when we did a direct pharyngoscope, we noted that he had a right posterior lateral pharyngeal wall injury, and he had a Scharfer grade 2 laryngeal injury with no associated vascular injury, both clinically and on imaging. So he required a tracheostomy for plus or minus 3 weeks, and his stay was then complicated by deep neck space infection, which required an incision and drainage. He is also subsequently developed a pharyngocutaneous leak, which we managed conservatively, and he was also on nasogastric tube fist due to aspiration because of insensate right supraglottic larynx. He is currently still admitted. We successfully decannulated him, and his nasogastric tube is out and is fitting quite well. So, and then the second case is a 45-year-old male patient who sustained a stab in zone 2 of the neck as well on the left side, just below the hyoid bone as well. So he subsequently had a CT angio done, which also could not exclude an aerodigestive tract injury. He had a left subclavian artery dissection, which was managed conservatively, and on subsequent CT angiography that had completely resolved. He had also suspected tracheal injury. He had bilateral pneumothoraces and the pneumomediastinum. And if we look at both these cases, the similarities are that they are both penetrating zone 2, level zone 2 of the neck. But the learning point really in these cases is that the site of the entry wound or the external wound doesn't necessarily correlate with the extent of the internal injuries. As you can see in the first case, the patient slit his throat at around about level 2, just below the hyoid bone, and subsequently developed injuries at almost the same level. But in this case, it highlights the importance of the trajectory of rather than the trajectory of the injury, rather than the site of the external wound, which sort of like brings us to the again to the discussion of the limitations of the use of zone-based approach versus the non-zone-based approach in managing these patients. Because certainly the step in zone 2 of the neck, we wouldn't expect a patient to get a bilateral pneumothoraces and pneumomediastinum. Certainly the trajectory should have been pointing quite inferiorly. So this patient was intubated for airway protection. He had moderate surgical emphysema. Our cardiothoracic colleagues did an esophagoscopy, a flexible esophagoscopy, which was normal at bedside. And he had bilateral intercostal chest drains inserted. And the suspected tracheal injury was managed conservatively, and the patient was extubated after 48 hours successfully. So this brings us to an interesting topic. As we all know, traditionally, the neck, in terms of if we're looking at a neck trauma or penetrating neck trauma, traditionally the neck was divided into zone, with zone 1 extending from the inferior border of the cricoid cartilage up to the clavicles and the suprasternal notch, and zone 2 between the lower border, between the lower border of the mandible and the cricoid cartilage, and then zone 3 being from the lower border of the mandible up to this skull base. But if we look at a bit of the topographic anatomy of the neck, you will get a sense of that it is actually more important to know the anatomy and the structures which are involved in the neck, so that you get a sense of so that you get a sense of a clinical index of suspicion in terms of which structures can be damaged, depending on 1, the site of the external wound, 2, a comprehensive clinical examination, taking note that the site of the external wound doesn't necessarily indicate or correlate with the extent of the internal damage. So just a recap of the anatomy of the neck. We all are, I think, well versed about the fascial planes of the neck. We've got the superficial fascia, the investing layer of deep cervical fascia, the visceral layer, which sort of like envelopes your thyroid gland, your trachea and your esophagus are there. And we also have got the vascular compartment with major vessels, that is your internal carotid artery, internal jugular veins with associated nerves as well. And then you've got your prevertebral component. So a detailed knowledge of the anatomy of the neck is also of paramount importance, as this is of importance in terms of your suspicion of associated injuries. Again, if we look again at the anatomy of the neck, this image basically shows that the neck is a complex single unit, and the simplicity of the zone-based approach doesn't necessarily explain the complex structures that you find in the neck. So this is basically shows you some of the most important structures that you can get injured in penetrating neck injuries. So if we look at the neck zones versus the no zone approach, this is still a debate among the trauma surgeons, and it largely remains institution specific, as well as because it depends on the expertise available, and also institutional factors play a major role. You find that in centers where especially in the context of our African settings, where we don't have the luxury of CT scan or CT angiograph if it always available, or esophagograph studies, they are not always accessible to all of us. So this sort of like affects your approach to these penetrating neck injuries. So this is quite still an area of debate, and as F alluded previous, that the institutional factors will really play a major role. Because if you look at the no zone based approach, you sort of like rely more on your clinical examination findings supplemented by your imaging, so that you avoid missing major injuries. So historically, before World War II, penetrating neck injuries were managed expectantly. However, the mortality rates were as high as 35%. And then this led to the employment of mandatory exploration until the 1990s. However, this was also associated with high rates of negative exploration. So, and then after the 1990s, we then came to the zone-based approach in trying to combat or trying to reduce the high rates of negative explorations from the mandatory exploration approach. So the zone-based approach was based on the relative ease of access of zone 2 of the neck. And as we know, if we look at the anatomy of the neck, it is quite difficult to access sort of zone 1 and zone 3 injuries. So the early algorithms for penetrating neck trauma favored mandatory exploration for zone 2 because of ease of access, and then recommended diagnostic procedures prior to surgical intervention for zone 1 and zone 3 of the neck. So if you put everything into context, the question really is, do all zone 2 penetrating neck injuries require surgical exploration? This is actually still of debate even nowadays. And the other question is, should all zone 1 and 3 injuries undergo a specific extensive battery of diagnostic tests? And the third question is that, could selective patients be actually managed non-operatively or conservatively? Well, we see what literature says. So you will see that this issue of mandatory versus selective management of neck wounds is still of debate, with the proponents of mandatory exploration, arguing that you can miss potentially life-threatening injuries by a selective management approach. And those who favor selective approach, the proponents of selective approach sort of like say, most injuries can be diagnosed by pre-operative workup. And again, if we look at the skills and resources available, the proponents of mandatory exploration, they argue that selective management requires more skill, more manpower, more experience, and sort of sound clinical judgments, with additional spatial diagnostic procedures which are also required. And then if we look at our, in the context of our African setting, some of these special diagnostic procedures may not be at our disposal. And then with this selective approach team saying that, selective care will reduce unnecessary exploration by a surgeon who is inexperienced in trauma. And then if we compare again the length of hospital stay, some studies have shown that the length of hospital stay is basically similar for patients with a negative exploration and patients who are managed conservatively. And with, again, no advantage of a negative exploration being found. And then, again, the proponents of mandatory exploration, they argue that if occult injuries are delayed, morbidity and mortality will increase. This is particularly for missed esophageal injuries, which can be of high morbidity and mortality. And the proponents of selective management arguing that it has not been shown, delay actually has not been shown to significantly increase morbidity and mortality of occult injuries. And then again, if we look at patient care, if you know, the proponents of mandatory approach, they sort of argued again that active observation requires a concept of continuous collaboration among trauma team members, you know, and yes, it reduces unnecessary surgical exploration, but you sort of like need sort of proper algorithms and proper handover procedures so that major injuries are not missed. And with the selective approach, team emphasizing on the availability of experienced trauma medical staff for monitoring these patients. So again, in the Eastern Association of Surgery for Trauma 2008 guidelines, they concluded that both approaches were justifiable and safe. Again, I think the most important thing to note is that for you to employ a selective based approach, you also need, one, the expertise, and you also need adequate sort of like investigation studies at your disposal so that you can employ this sort of like conservative approach. Again, Harris et al. In 2012 in the Southeast London Trauma Center, they showed in their study, they showed that selective management reduces the length of hospital stay and lightens the surgical workload. It also casts the cost without, casts the hospital cost without effect on either morbidity or mortality, which is quite important in our setting. Again, this was a study which was done here in Cape Town at Groote Hospital, where they analyzed about 203 patients. That was between 2004 and 2005. And in this study, basically, the aim was to validate the protocol of a selective non-operative management in penetrating neck trauma patients. So they concluded that selective non-operative management of penetrating neck injuries based on clinical examination and selective use of adjunctive investigational studies is actually safe in a high volume trauma center. Again, one of the most important things in the selective approach or the no-zone based approach is the role of physical examination. It is of paramount importance that you do a comprehensive physical examination. As it has been shown, there's level 3 evidence that it is more than 95% sensitive for detecting arterial and aerodigestive injuries that require repair. However, in these patients, you need to have a low threshold for imaging studies due to the high mortality of missed injuries. Again, the role of CT scan, the multi-detector helical CT angiogram is sort of like made is of real value in these penetrating trauma patients. So this investigation is done in addition to your physical examination findings. So in the systematic review, they looked at the role of CT angiograph in the no-zone approach, or sort of like in the more conservative approach era for penetrating neck trauma. So they found that in addition to your physical examination and in stable patients with hard signs or soft signs, it has a sensitivity of 94 to 100% and a specificity of 96 to 100% in detecting upper aerodigestive and vascular injuries. So they concluded that the CT angiography is, it has got a reliable high sensitivity and specificity for penetrating neck injuries in patients with soft signs and selected patients with hard signs. That is, patients who are stable or hemodynamically stable with hard signs. So, and in their results, they supported a no-zone-based approach, based on CT angiography in stable patients. This, however, you need to note that this is in addition to your physical examination findings. And then this brings us to sort of like more ENT related penetrating neck injuries. I wouldn't go much into vascular injuries because they are managed by the vascular teams. So basically, I will look at the pharyngeal injuries, and I'll look at the laryngeal and upper cervical tracheal injuries. So basically, I've already mentioned the hard and sort of soft signs of laryngeal or laryngotracheal injuries. So for laryngeal injuries, we classify them according to Scheffler's classification, which groups them into 5 categories based on the degree of injury, the symptoms, and the signs on your examination. So grade 1 injuries are sort of like mild injuries with mild symptoms. Patients can get mild voice change. They can be dyspneic with a mild cough, and on your examination, they don't have any sort of fracture of the laryngeal-tracheal framework. They may have mild hematoma or lacerations, which are sort of like amenable to a conservative approach. I will talk later about the conservative based approach. And then you also can get moderate injuries where patients can present with a stridor or compromised airway with some hemoptysis, with edema or hematoma of in the larynx, however, with no exposed cartilage or with no laryngeal framework fractures. So if you look at the first and second group, these patients are both sort of managed, amenable to a conservative management. And then if you look at laryngeal injuries, who most of the times require operative intervention, be it to secure the airway, to repair the mucosal lacerations, or to align your laryngeal framework. So if we look at the first group, that is the group with the mild laryngeal injury, generally, these patients, they are managed medically and do not require surgical intervention. And you also have got some adjuncts to your sort of your medical management. That is use of steroids, use of adrenaline naps, voice rest, and also you can employ, like humidified air to sort of like improve your mucociliary clearance. And then if we look at the second group, these are the patients you may need to do serial examinations because they may sort of progress from a grade 2 to easily to a sort of like grade 3, or the airway compromise may worsen if you have got a small sort of like and an expanding hematoma. They, however, infrequently may require tracheostomy. For example, in the first case that I presented, it was a patient who had a laryngeal injury. We ended up doing a tracheostomy, for the anticipated prolonged intubation, and we allowed the larynx to heal, and we successfully decannulated him in about 3 weeks. And then if we look at grade 3 injuries, either tracheostomy or surgical repair are often required for these injuries. And you also need to perform a direct laryngoscopy and esophagoscopy, because most of these laryngotracheal injuries, in about in up to 5% of cases, they are associated with the pharyngeal and esophageal injuries. And then if you, for example, you've got either disruption of the anterior commissure, a major endolaryngeal lacerations, tear of the vocal cords, or immobile vocal cords, cartilage exposure, or displaced laryngeal cartilage framework, these injuries may actually require a surgical intervention. And then if you look at the fourth group of laryngeal injuries, these patients usually require surgical repair with or without use of stents. You know, you have to know that stents will also come with sort of like their own pitfalls, like a granulation tissue, just to mention a few. And actually, if we look at the fifth group of patients, these are the patients with sort of like disruption of the laryngotracheal framework. These injuries usually occur either above or below the cricoid cartilage. And then the airway usually is temporarily established through the neck with the use of the endotracheal tube through the neck wound. And then they often require a complex sort of like laryngotracheal repair through a lower cervical incision. I won't go into much, in the interest of time, I won't go into much description of these repairs. So if we look at the conservative management, these are sort of like your adjuncts to your medical management. This is important for your the first and second group, or Chandra 1 and 2 sort of classification, in which you may want to nurse your patients with head elevated to minimize the edema and decrease, to manage laryngeal secretions. And you want to manage them on voice rest. This also minimize, exacerbation of the laryngeal edema. Use of humidified air improves your mucociliary clearance. No supporting data of the use of steroids, but with our experience that in most patients who present with upper airways obstruction, they usually respond to steroids and medical management with adrenaline naps. And you can also put these patients on anti-reflux medication to prevent a reflux, which may increase your inflammation and edema. And then if we look at the tracheal injuries, most injuries or like small tracheal wounds where there is no loss of tissue or the tracheal edges are well opposed, most of these injuries, they heal spontaneously within 48 hours. And there is definitely a role of non-operative management in these cases with the use of either oral tracheal intubation or nasotracheal intubation. And you should note that in these patients, the cuff of the ETT should be inflated below the site of the wound so that you prevent worsening surgical emphysema or pneumomediastinum. This is exemplified in the second case that I just presented previously, where the patient presented with the suspected tracheal injury and was managed conservatively and actually successfully extubated in 48 hours, which shows that there is a role of a conservative approach in these patients. However, unstable patients with tracheal injuries, you need to take them to the operating room for emergency neck exploration with a subsequent panendoscopic evaluation, and then the management will sort of depend on the extent of the injuries. And then in this article, basically they looked at the role of conservative management in management of tracheobronchial injuries. And they concluded that, conservative management is effective regardless of the mechanism of injury, the length, or the site of the injury. But however, you need to have a strict patient criteria, we need to individualize your patient management. And they also concluded that the conservative approach is actually more suitable for membranous injuries, and sort of like some selected patients with cartilage injuries can be managed conservatively as well. And if you look at pharyngeal injuries or pharyngoesophageal injuries, you need to have high index of suspicion of these injuries, especially in penetrating zone 2 neck injuries. You need to note that esophagography, especially in high pharyngeal injuries, is unreliable. As Armstrong et al., they showed that actually esophagography only identified about 62% of pharyngeal injuries, and with rigid esophagoscopy, detecting all the injuries in their series. So if you sort of divide your hypopharynx into the supraarytenoid and infraarytenoid compartment, you find that the supraarytenoid injuries are more amenable to non-operative management because of the high sort of like the space in that supraarytenoid compartment. And if you look at the surrounding structures, it is well protected by your constrictor muscles, making these injuries more amenable to non sort of operative management. However, your infraarytenoid, you need to be very careful with your infraarytenoid injuries, and you need to manage these like esophageal injuries. There is a role in managing these injuries conservatively. However, I won't go into much detail about managing esophageal injuries, since they are usually managed by our cardiothoracic colleagues. So Stanley et al. In a retrospective study of 47 patients with hypopharyngeal injuries noted no complications in supraarytenoid injuries versus about 22% complication rate for the infraarytenoid injuries, highlighting the importance of your clinical examination in terms of determining if your injury is a high pharyngeal injury or it's a low sort of like infraarytenoid injuries, which are associated with high complication rates. This is, I should say, a bit of an outdated study, but which still sort of like applies to our current, settings. So they basically looked at a conservative management approach in managing isolated hypopharyngeal wounds. And in this study, they concluded that conservative management is a good and safe option to manage isolated hypopharyngeal injuries when indicated. So basically, in their series, these patients were managed with nasogastric tube feeds, and they were kept nail to os, and they usually got esophagography on day 7. And again, this brings us to this audit of penetrating neck injuries, which was done at Pietermaritzburg here in South Africa. And they sort of concluded also that selective non-operative management in penetrating neck injuries is a safe and appropriate management strategy. And they also supported conservative management of isolated pharyngeal injuries and sort of small non-destructive airway injuries. And also, as part of their conclusion, they concluded that if CT angiography alone has a significant false positive rate, so it is of paramount importance to sort of like tally your comprehensive physical examination findings with your CT angiograph findings to sort of like to reduce the false positive rate associated with the CT angiogram. And then this brings us to the conclusion that a good clinical assessment of that is your history and your physical examination remains the cornerstone of managing these penetrating neck injuries. This is basically a summary of how you can sort of like approach these penetrating neck injuries. So as I had alluded previously, if your patient has got hard signs, that severe active bleeding, patient who is in shock, not responding to fluid resuscitation, patients with rapidly expanding hematoma, suspicious of a major vascular injury, patients with large glowing wounds or major hemoptysis are to be taken to the operating room quite urgently. And there is a role for active observations in selected patients with hard signs and in patients with soft signs. However, taking into account the expertise available and the investigations which are at your disposal. I didn't go into the management of penetrating neck trauma in the pediatric population, but there is certainly a role for a conservative management as well in penetrating neck injuries in the pediatric population, taking into account the side effects of use of some of the ionizing sort of like radiation and contrast studies in the pediatric population. So you need to sort of like be quite highly selective in terms of your investigations, or sort of like investigate when it's absolutely necessary, especially in the pediatric population. But however, the management as well in pediatrics, there is a role for a sort of like a conservative management in selective patients in the pediatric population with penetrating neck injuries. And again, in pediatrics, you sort of like hard signs. You can get hard signs which are indicative of urgent, which are indicative for urgent intervention where you need to take the patient to theater. And patients with soft signs and selected patients in the pediatric population with hard signs, they are actually even as well amenable to conservative management approach. I think that is my last slide, and those are some of my references. Thank you very much.
Thank you very much, Charles, for a very concise and comprehensive overview of penetrating neck injuries. Firstly, I'd just like to invite the audience to comment in the chat function regarding two aspects in your practices at your local institution. Firstly, whether you're practicing conservative management or mandatory exploration of the neck and penetrating neck injuries, and also perhaps whether you're practicing surgical exploration or immediate repair of hypopharyngeal injuries, or the conservative approach. We're very fortunate to have Professor Nicol and Professor Fagan with us today. They're both extensively published in this area, both authoring chapters in both Scott Brown and Cummings. So I'd just firstly like to invite Professor Nicol to comment. Professor Nicol, are you there?
Thank you, and thank you, Dr. Moyo, for your presentation. Yeah, I think as most of you know, in South Africa, as trauma surgeons, we use the selective non-operative management of penetrating neck trauma. And this has been very successful in our practice. And 80% of our patients we manage with this kind of algorithm. We've also moved to what Dr. Moyo was referring to, which is the no-zone approach in penetrating neck trauma. And there's a very nice study that was done in Pietermaritzburg that showed that it's only about in 2/3 of patients is the injury that you have in your neck is actually located in that zone. So in about 1/3 of patients is going to be distant from the zone. And this is one of the reasons why we moved to that no-zone approach. And our kind of policies now with the majority of pharyngeal injuries, we treat non-operatively with nasogastric tube feeding for a period of 10 days. But we're still operating on the esophagus. Although there have been some reports that people are moving towards, with small contained leaks, treating the esophagus conservatively. But we've had 2 disasters in that management protocol. And so we tend to operate in the esophagus, but the pharynx will treat with nasogastric tube feeding for 10 days. And this has proven very successful. We repeat the contrast swallow after a period of 10 days. If there's still a leak, we continue with nasogastric tube feeding. But if there's no leak, the patients are usually well managed without any complications.
Thank you. Thank you very much, Professor Nicol. Professor Fagan has a question.
Andrew, thanks for joining us. Perhaps what wasn't covered was the high velocity injuries. Would you like to comment on how the management of the high velocity gunshot injuries would differ from what's been presented?
Yeah, thanks. Yeah, thanks, Johan. Yeah, you know, we don't see many high velocity injuries because they usually end up in the mortuary, Johan. So you know, the occasional cases we get is usually a patient that's requiring basically damage control surgery. And in those sort of cases, we really just we kind of stenting vessels and doing kind of basically life-saving sort of stuff and trying to get the patient through the next 24 hours for more reconstructive surgery after that 24 to 48-hour period when the patient is more stable. So yeah, I think particularly in the neck region, it's quite uncommon to get a survivor from a high velocity gunshot wound because of the proximity of structures.
Thank you very much, Professor Nicol. No questions for now, just perhaps a question from my side to yourself and Professor Fagan. We know we practice conservative management of hypopharyngeal injuries here, but perhaps in cases where you're exploring the neck for another indication in the acute setting, whether it's associated vascular injury or the neurosurgeons are taking the patient to theatre for craniotomy, etc. Do you think there's then place for exploring the neck and perhaps attempting to repair hypopharyngeal injury?
Thank you. Yeah, I don't think so. I think if you're going into the neck, absolutely. But if the patient, is being operated on for by the neurosurgeons, another anatomical area, I really don't think there's any point in doing that. But if obviously we're going into the neck for a vascular repair, it's absolutely crucial then, I think, that you attend to that pharyngeal injury and sort that out, yeah.
Thank you very much. There is one question, Charles. There's a question regarding the role of ultrasound and Doppler, noting that it's cheap, I think, comparably to CT scan. I'm not sure what that is in relation to. I presume they're querying in relation to a vascular injury. Would you like to comment, Dr. Moyle?
Yeah, so unfortunately, I didn't go much, or I didn't dwell much on vascular injuries, but there is definitely a role. Maybe Prof. Nicol is at a better position to answer that question.
Yeah, we tend to use CTA, but certainly in the zone kind of 2 areas we can get fairly decent access. You can follow up patients with Doppler studies. There's no doubt about that. I'm looking for carotid artery injuries, but obviously there's a wound overlying it. There might be subcutaneous emphysema present there. So in the early stages, I would head for CTA to detect vascular injuries. We're only doing CTAs if the patient has a hard sign, and that's kind of our indication for CTA as you demonstrate in your algorithm.
Thank you, Professor Nicol. And has CTA then replaced conventional 4-vessel angiography in your unit?
Yeah, completely. Yeah.
I'd also like to invite Dr. Baidu from Ghana to perhaps comment on the practices in their unit.
Right. Good morning, everyone, and thank you for a comprehensive presentation. In Ghana, practically, we've always shifted seemingly unintentionally to conservative management and then the known zone systems, so that we go through all those hard and soft signs, and then do a CT angio if necessary. Otherwise, it's a clinical examination and observation, and then necessary approaches if they are indicated. Thank you very much.
Thank you very much, Dr. Baidu. There does not seem to be any more questions on posted. So that concludes our meeting for this morning. Thank you very much to Charles for a very comprehensive and great presentation. And thank you very much to Professor Nicol and Professor Fagan for joining us this morning. Thank you.